Okay, so hello to everyone. My name is Dr. Tome Piperevaliev from Macedonia. I am a resident in oral surgery and I am working in one of the biggest clinics in my country, private health organization Dentiția, something that makes me really proud. First of all, I hope that all of you are well and healthy and in a safe, because in this terrible time of humanity, I think that the best jobs that we can do are staying in home, learning, and sharing our experience together. Today, on my honor, I'm really happy that I have a possibility to be part of this wonderful group of webinars and lectures organized by Open Dental Community. Today, I will talk about surgical and prosthetical options for treating edentulous mandible. And I will say a few words about the problems that our patients and we as doctors are facing with edentulous mandible. We will talk about the role of the available bone and the prosthetical solutions over the implants in edentulous mandible. And normally, I will share some of the cases made in our clinic or how we are treating edentulous mandible. So let's begin. The major problem that our patients and we as doctors are facing in edentalism is bone resorption. Bone resorption as a result of disuse atrophy. In the book of Carl Misch, we can find an interesting information that after extraction of the mandibular teeth, we are losing around 4 millimeters of bone during the first year after the treatment. Bone resorption as a major problem leads us to a lot of anatomical and functional problems, like collapse of the vertical dimension as a result of the lowering of the inferior third of the face, a lot of aesthetical problems as a result of losing the support of the lips and teeth. But I'm sure that the most difficult problems are the disorders of temporomandibular joint. And normally there are some functional problems in mastication, speech, swallowing, and normally social and psychological problems for our patients. Our patients, as a result of insufficiently processed, mechanically processed food, are exposed to the risk of general health diseases like diabetes mellitus, chronic kidney disease, chronic inflammatory changes to the gastric mucosa, or coronary heart disease. So the point of our treatment is to solve the problems in orofacial system, to restore the functions, and to prevent the general health diseases. But our treatment options are mostly depending on the quality and quantity of the bone. Its volume, its shape, and its quality and quantity strongly influence the decision of surgical and prosthetical treatment. In 1985, Misch and Judy made a classification of the bone based on its external architecture and its quantity. And they divided the bone in 4 divisions, from division A to division D. First 2 divisions, or division A, abundant bone, and division B, barely adequate bone, are mostly preferable for fixed prosthodontic constructions. Those 2 types of bones do not need additional surgeries, maybe some osteoplasty or a small lateral bone augmentation in division B type of bone. Other 2 divisions, or division C, compromised bone, and division D, deficient bone, are mostly preferable for removable prosthodontic constructions. If we want, or our patients insist for fixed prosthodontic construction, firstly, we must think about additional surgeries like vertical or lateral bone augmentation, maybe sinus lift in the upper jaw, or transpositioning of the inferior alveolar nerve in lower jaw. But today we have one option more to avoid additional surgeries by using specially designed titanium cortically fixed plates. Those plates are specially designed to be adjustable to the bone morphology, and they are connected with the small screws to the cortical part of the bone. And I'm sure that the most information we can learn from the president of our community, Dr. Henri Diederich, about this system. So what are our prosthetical solutions over the implants for treating edentulous mandible. They are divided in two big groups: removable prosthodontics and fixed prosthodontics. Removable prosthodontics or overdentures can be retained to the implants using ball attachments, or they can be bar retained overdentures. For this treatment, we need minimum 2 or 4 implants inserted in the anterior part of the mandible between the mental foramen. And this situation, this solution is indicated in case of highly resorbed bone in the posterior part of the mandible. And when we are predicting to have a problems in the interarch relationship with fixed prosthodontic constructions. And normally, this construction is lower cost for our patients. In group of fixed prosthodontics are depending screw-retained denture designs on 4, 6, or 8 implants, and the conventional approach or screw or cement-retained bridge on 6 or 8 implants. I searched on PubMed and I found an interesting study published around 15 days ago, which inspects the impact of the implant superstructure type on the oral health-related quality of the life in edentulous patients. This study includes 72 completely edentulous patients that are divided in 2 groups. In 2 groups are patients treated with removable prosthodontic or implant overdenture, and in the second group are patients treated with fixed prosthodontic or implant fixed complete denture. And the conclusion of this study is that there is no significant differences in quality of life depending on the implant superstructure type. Maybe some expectations in masticatory function. So now I will begin with presenting some of the cases made in our clinic. But before I begin, I want to mention 2 things. All of the cases are made in collaboration with my colleagues in clinic, and all used implantological and prosthetical constructions are part of Open Implant System Beirut. I will begin with removable prosthodontic constructions. I will show bar retained overdenture, but this is very important slide for me because when we are going to plan bar retained overdenture, we must always keep in mind that we need 15 millimeters space between the bone level and occlusal plane. This space is needed to accommodate all the implant superstructures needed for the retention of the denture. I will present my first case. This case is 1 year old, and I think that this was the first case in my clinic made by using the compressive MS implants. Case is immediately loaded 2-piece compressive implants inserted in the anterior part of the mandible that are used for retention of overdenture by producing the screw-retained mill bar. On the left picture, we can see the pre-initial situation, and we can see that we have highly resorbed bone in the posterior part of the mandible, and that's one of the reasons why we decided to choose these treatment solutions. On the right picture, we can see the inserted compressive MS implants. Those are tissue level implants with multi-unit abutments. And here we can see 3D CBCT 1 year after the implantation. And this is important slide because here we can get a lot of informations and a lot of answers why we decided to do an immediate loading of those types of implants. Because when we want a success in an immediate loading, we must respect some very important requirements. The first one requirement is the length of the implant. For an immediate loading, it must be minimum 10 millimeters. Here we have 3 implants with 12 millimeters and 1 implant with 10 millimeters. The second very important requirement for success in immediate implantology, immediate loading, is the torque that we achieve while inserting the implants. And it must be minimum 35 newtons on centimeter. And the third requirement is the quality of the bone. For an immediate loading, it must be type D1 and type D2 quality of bone. I'm sure that all of us knows that in the anterior part of the mandible, between the mental foramen, mostly the quality of bone is type D1 and type D2. So why we decided to use this treatment solution for this case? Because this concept is scientifically and clinically proven more than 20 years. This concept enables our patients to get a restoration quickly, efficiently, and immediately after implant placement. And very important thing is that milk bar is playing a role as a rigid splint fixation over the implants. This rigid splint fixation acts as a safeguard to the bone implant interface against masticatory forces. For an immediate loading, if we want a success, we must limit the micro movement at the bone implant interface within the tolerance around 100 micrometers. After 1 week of inserting the tissue-level compressive MS implants, we are taking the final impression. In this situation, we used specially designed transfers for closed tray method supplied with plastic cups. In our clinic, we are always splinting and connecting the caps with flowable composite and acrylic pattern resin just to prevent any micro movements during the setting of the impression material and during the laboratory procedure. Here we can see the final impression with the analogs. This final impression will be used by the dental technician to produce the final cast. Here we can see the final cast with the analogs on which the dental technician used special designed burnout abutments for producing the screw-retained milled bar and the denture. In the next visit, we have a task to try in the milled bar for a passive fit. And this is very important. Every construction that is screw-retained to the implants must passively fit. If we need pressure to insert the construction over the implants, then there is a problem. And the problem is located in the final impression. And we must repeat this stage of work to avoid additional problems like screw losing or screw fracturing, etc., etc. In the same visit, we're registering the interjaw relationship using occlusal rims. And next visit is wax training of the complete denture just to control the retention, stability, occlusion, articulation, aesthetic, tongue space, and to identify some errors before the denture is almost finished. And here we can see the pictures of final construction inside the patient's mouth. The next case is bar retained denture over 4 root form implants that are delayedly loaded after 4 months. Root form implants are tapered body design implants with internal conical connection and internal hex, and they have the same platform no matter which diameter of the implant we are going to use. After the anamnesis, diagnosis, and planning, in discussion with the patient, we decided firstly to treat the lower jaw. First, we extracted the lower teeth, the residual lower teeth, pre-surgically prepared patient with antibiotics because she was medically compromised with diabetes mellitus. And we decided to do a 2-stage implantology. In the first stage, we inserted 4 implants in the anterior part of the mandible between the mental foramen, and we waited for a period of osseointegration, 4 months. Here we can see the picture after 4 months of implantation before beginning the second stage. On second stage, we are inserting gingiva formers, but always in our clinic, before inserting gingiva formers, we are taking a preliminary impression using an alginate impression material for producing wax rim about registering interjaw relationships in the next stages. Here we can see the emergence profile after 2 weeks, and we are ready for the final impression. We used transfers for closed tray method with plastic caps. Here they are connected with flowable composite. And here we can see the final impression with the analogs. In the same visit, we are registering the maxillomandibular relationship with wax rim. And here is the final cast with multi-unit abutments. Later, I will say a few words about and few informations about the multi-unit abutments used for screw-retained constructions, while I will present the fixed prosthodontic constructions. On the final cast, the dental technician used straight or angled burnout abutments to produce screw-retained milled bar. Next visit is trying of the milled bar. Firstly, we are inserting the multi-unit abutments over the implants in patient's mouth, and we have to try in the milled bar. As I said, it must passively fit always. The next visit is controlling the aesthetic, occlusion, articulation, lip and cheek support, and identifying some errors. And here we can see the final construction. On lower picture, we are seeing the inside surface of the denture with clips inside. And that's the final construction inside the patient's mouth. So what are the advantages of overdentures? Overdentures are preventing the bone resorption in the anterior part of the mandible. They give us better stability and retention for the denture, improved aesthetic, better support for the lips and cheeks, and they give better functioning of mastication, speech, etc., etc. And as I said, this is the lower cost or cheapest treatment solution for our patients. Next cases are about fixed prosthodontics. I'm going to present two cases made in our clinic. One is screw-retained bridge design, and the second is cement-retained bridge design that are retained on 6 implants inserted in the lower jaw and are conventionally loaded after 4 months. But before I continue my presentation, I want to mention that in open implant system by root, we have one more option of connecting the prosthetical construction with the implants without cement or without screws. And that can be achieved only by using the special designed conometric cups or conometric connection. And I'm sure that our audience learned a lot of things about conometric connection 3 days ago on the webinar by our friend from Lithuania, Dr. Dainius. So let's continue. As I said, firstly, I will present a screw-retained bridge, metal ceramic bridge on 6 implants. So what are the advantages of screw-retained construction? The major advantage is that there is no cement. So the risk of peri-implantitis as a result of excessive cement is eliminated. Those constructions are easier for removing when we need some repairs or some additional surgeries over the implants. And this is the favorable treatment solution when we are lack of interocclusal space. When we have interocclusal space lower than 8 millimeters, we must think about screw-retained constructions. One of the disadvantages of this construction are the holes on occlusal surface that disturb occlusal morphology. As I said, for screw-retained constructions, we are using multi-unit abutments. In open implant system by root, they are divided in 2 groups, small multi-units and regular multi-units, and they can be straight or angled by 15, 30, and 45 degrees. Multi-unit abutments are special designed for root form implants to correct the angulation between the implants from 60 to 105 degrees. In this slide, we can see the X-ray immediately after implant placement. And as I said, as we can see, we used special designed screw bone builders on 2 implants. Those screw bone builders, or GF0, are acting as a maintainer of the space between the soft tissue and the platform of the implant. And they are preventing the soft tissue to cover the platform of the implant and give a possibility to the bone to migrate and fill this empty space. And this option will lead us to a better also integration of the implants. After 4 months, we are beginning with the second stage by inserting the gingiva formers. And after 2 weeks, when the emergence profile is ready, we are taking the final impression in this situation with closed tray method. And in the same visit, we are registering the interjaw relationship. In this case, we used a patient's old complete denture. Here we can see the picture of final impression with the analogs and the final cast. In collaboration with the dental technician, we decided to use 4 straight multi-unit abutments and 2 angled multi-unit abutments. Here we can see the pictures from the laboratory procedure on which the dental technician used burnout abutments, straight and angled, to produce the metal frame of the construction. Next visit is trying of the metal frame. Firstly, we are inserting the multi-unit abutments, and we are trying the metal frame over the multi-unit abutments. And here we can see the picture of the final construction inserted in the patient's mouth. And the last one case is cement-retained bridge on 6 implants, very conventional approach. Here we can see X-ray at the first visit of the patient, and after investigation, we diagnosed severe periodontal disease. And after discussion with the patient, we decided to extract the lower teeth because there was severe periodontal disease with a lot of mobility to the lot of teeth in lower jaw. After 6 months of period of healing period, we inserted 6 implants and waited 4 months for loading of the implants. Here we can see X-ray immediately after implantation. This is 6 months after first visit of our patient. And here we can get information about the dimensions and diameters of the inserted implants. And after 4 months, we are beginning with the second stage by inserting the gingiva formers. After 2 weeks, the emergence profile is ready, and we take final impression with closed tray method. I want to mention that in open implant system by root, we have transfers for open tray method, transfers for closed tray method, and specially designed scan bodies for digital impression. I'm sure that I think on Sunday we are going to learn a lot of things about the digital protocol with root implants by our friend Dr. Karampinis. Here we can see the final impression with the analogs. In this case, we connected the analogs with acrylic butter resin. And this is the final cast on which, together with dental technician, we decided to use anatomical abutments. They can be straight or angled, 15 and 25 degrees. And no matter that our abutments have internal hex connection with implants, we are always splinting and connecting them just to allow me to accurate transferring the abutments from the final cast to the patient's mouth. And this is the metal frame on the final cast and the patient's mouth. And here we can see cement-retained metal ceramic bridge over 6 implants loaded after 4 months. Dear colleagues, every tooth in a man's head is more valuable than a diamond. I'm sure that we must motivate and educate our patients to keep their teeth and to avoid the situations of edentulism. Thank you for your attention.
So, Dr. Tome, thank you very much for this wonderful presentation. It was very didactic. It was very nice done. Very interesting. Dr. Tome, I have a question. What is your choice doing delayed loading or immediate loading with bar-retained prosthesis?
Sorry, I didn't hear you.
When do you? How is your choice done? You do either delayed loading,
yes,
or do immediate loading with the bar retained?
Yes, everything depends on the situation. As I said, firstly, we must achieve very important requirements for immediate loading. To be honest, I'm preferring always delayed loading after 4 months. But everything depends on the situation of the patient's medical situation, health situation, the quality of the bone, number of the implants, torque that we are achieving while inserting the implants. A lot of factors are included in decision.
Okay, I see. Because myself, I do a lot of immediate loading with overdenture, and in general, for instance, I never do delayed loading with a bar. So said I was a little bit surprised. So I may tell you that I have long-term results over 15 years, and that is that's quite interesting. So it was for me interesting to see and also know why do you do delayed loading with overdenture. But for sure, when you're doing delayed loading, you're always on the safe side. That's for sure.
Yeah, that's the reason.
Yeah. So we have here a question from our colleague Dr. Hassan Basit from Syria. He's asking us what are the kinds of clips that they are using over the mill bar.
My dental technician, as I said, firstly use burnout abutments for producing the metal construction, and I think he's preferring to do a customable clips with customable made produced clips for the retention of the overdenture.
Okay, I see. Interesting. So another question. I saw in your case where you did delayed loading, you put at one case the GF0 or screw bones on 2 implants, but not on the other implants. So what was the motivation, or why is the choice to put on these 2 implants this GFO?
The reason why we inserted GF0 in this case was that we needed some bone graft over the implants, and to prevent incorporating the soft tissue around the implant, we firstly covered the implant with bone graft and inserted the special designed screw bone builders just to allow to organize the graft.
Okay. Do you have some experience already with the GFO screws?
Only this.
Only this.
Only this.
And did you already use econometrics for the one-piece implants?
No, not yet. But I'm planning to start.
Okay, so yes, it will be very interesting. And then another question that allow me to ask you: what about the education of the patients? How motivated are patients to take care about the mouth? Are they going a regular way to the dentist?
Yes.
Take care of their mouth. How it's going on in North Macedonia?
We are preferring our patients to visit us every 6 months for a regular checkup, better hygiene, cleaning the teeth, and everything that is needed to prevent more severe complications in periodontal tissue, etc., etc.
And so it's a discipline to do it also, yes?
Yes, we need this.
Okay, great. Yes. What about dental tourism in your country? Do you have a lot of patients who are coming aboard?
Yes, the most of our patients are from Greece, because I'm working in Gevgelia, This is a small town near the border with Greece, and as a result of a cheaper treatment solution, the most of the patients are in our clinics from Greece.
Okay.
But no matter the price, I'm sure that we have quality work.
Okay, I see. How do you think the situation will be after the crisis now? Because patients, they may be afraid.
I'm optimistic, and I'm sure that we are going to have a lot of work. Look, now Corona is everywhere, on TV stations, on social media, in newspapers. A lot of misunderstandings, a lot of unknowings. But I'm sure that only together and united we can beat this virus, because in the future period we are going to face a lot of other problems, not only economical or financial problems, but psychological and social problems. But I'm optimistic that everything will be okay very soon.
Yeah. And I think, unfortunately, what will happen, our patients will have big problems all the time in the mouth, because it begins with a little problem. At the end, it will end with an extraction, and so on, so on. So I think for this, patients will also suffer a lot, and I think there will be a lot of work. Yes. There is another question here from our colleague Rabib Grabi, and he's asking you if you cover the operated area with a removable denture during 4 months of healing.
Yes. That was a two-stage approach. We are covering with the flap.
Okay. Another question here from Dr. Yasser Al-Afri. How can I connect between the bar and the denture? How can I connect between the bar and the denture?
Only with clips.
Yeah, only with clips.
Only with clips. For more information, I will need to ask my dental technician.
Yeah.
With clips for sure.
Yeah, but I think in general the lab will know the solutions, and I think it is like a pretzel line. So I think it's very common. It's very common. Another question here from Kavan Salah. So thanks for your beautiful cases. In the last case, full lower arch supported fixed prosthesis, did you think 6 implants was enough to support 14 units fixed bridge? Especially the patient appears young with upper national dentition.
Yes, the patient is young, around 40 years old, I think. But he has good quality of the bone, and we inserted implants longer than 10 millimeters. And I'm sure that we are not going to have problems in this situation. The next step after the Corona crisis is treating the upper jaw, because he has a lot of problems in maxilla.
What was also interesting to see in your case presentation is that you use the compressive MS implants.
Yes.
Maybe you have the possibility to show this another time, this compressive MS. You may show it another time. Yeah.
Yes.
On the slide.
Yes. Now.
So compressive MS.
Just to find it. Yes.
Yes. So I think these implants are quite unique. They are quite unique.
Very unique.
It may be interesting if you explain you a little bit how is your excitement about this type of implants.
I'm very good implants, because with compressive implants we can achieve a good torque, and the advantage of this implant is the multi-unit platform that gives us a possibility of producing screw-retained constructions. And there is no risk of losing the multi-unit abutments, like fracturing, screw losing, etc.
Yeah, and I think the design is done in the way the threads are designed in the way that you have a very nice and strong primary stability, and you may use it very nicely by flapless. Yes?
Yes.
So I think that is a very interesting indication, I think, especially also for elderly patients, because it is really minimal invasive treatment option.
Yes.
There's another question here from our colleague David Jagudev. What is the minimal length of implants you use in overdenture? 4 implants or 6 implants?
The minimum
minimal length of implants.
Yes, the minimum is 10 millimeters, but we are preferring to be, if we have possibility, to be 12 millimeters. And in anterior part of the mandible, we have that possibility.
Yeah, it's depending from the bone quality.
Yes, but minimum 10 millimeters.
Yeah. Okay. And until now, but you are quite young, so you don't have so much cases with complications. With complications, did you have one complication already, which may happen?
Till now, we have a lot of cases, but I don't have till now some big complication till now.
And
I hope that it will continue.
Yeah, okay, but maybe that you saw complications by other systems, or
I don't have experience with another systems.
Yeah, because you are quite young, so the future is yours.
Yes, thank you.
So I think we may conclude. So another time, thank you very much for this nice presentation you give.
Thank you. It was my pleasure.
We enjoyed it very much. And from my side here from Luxembourg, I send to you to Macedonia, to your home, to your country, all the best. Let's hope that you may start very fast to go back to our clinics, to our patients, and at the end that we are staying safe and healthy.
I hope so. Thank you. Good evening.
Thank you very much. Thank you for the audience to be with us, and hopefully we will see us tomorrow night for another webinar. Thank you very much.